Good day. As part of the adult immunization series, the subsequent slides will discuss hepatitis B virus infection as a vaccine-preventable disease with data from the Department of Health and Hepatology Society of the Philippines, Clinical Practice Guidelines for the Management of Hepatitis B in the Philippines 2021. The CPG was developed to serve as a guide for healthcare workers when choosing cost-effective, evidence-based interventions for the management of patients with hepatitis B infection in primary care. Evidence summaries are based on the best available scientific evidence at the time of formulation of the guidelines. It followed the widely accepted grade approach and ETD framework criteria, and recommendations shall hold and will be updated after 3 years or when new evidence becomes available. Bases for assessing the quality of evidence using the grade approach are shown in this slide. Hepatitis B infection is a serious problem worldwide. Despite the implementation of a nationwide expanded immunization program in 1995 to decrease its transmission, hepatitis B and the sequelae of its chronic infection remain as one of the leading causes of mortality and morbidity in the Philippines. In 2014, the Hepatology Society of the Philippines developed consensus statements on the management of hepatitis B in the Philippines using a modified Delphi process. These statements included guides on screening and vaccination, general management, indications for assessment of fibrosis, treatment, duration of antivirals, and monitoring. Recommendations on the approach to antiviral drug resistance and dealing with special populations were also discussed. Several international organizations have also published and updated their guidelines on this topic. They were, however, drafted in ideal settings, thus difficult to adapt on a wider scale due to limited resources. The WHO guidelines were primarily formulated to be used by low to middle income countries, scaling up their countrywide programs for hepatitis B prevention, care, and treatment. First clinical question: should vaccination be recommended to healthy adult patients with no evidence of hepatitis B immunity to reduce hepatitis-related outcomes? We recommend catch-up vaccination of healthy adults with no serological evidence of immunity or previous vaccination to decrease the incidence of acute hepatitis B. That's strong recommendation. Certainty of evidence is low due to serious indirectness and study design limitations. Among adults who have not been previously exposed to hepatitis B infection or whose exposure and vaccination status is unknown, the effect of vaccination on the risk of developing hepatitis B infection and its sequelae is unclear. Evidence on the benefit of vaccinating adult healthy populations in reducing hepatitis B-related outcomes requires evaluation. However, seeing the burden of disease, hepatitis B infection is a serious problem worldwide, affecting approximately 240 million people. Prevalence in the Philippines is 16.7%, or 7.3 million Filipinos in 2013. That's more than twice the average prevalence in the Western Pacific region. Hepatitis B and the sequelae of its chronic infection remain as one of the leading causes of mortality and morbidity in the Philippines. What are the vaccine's benefits and harms? 3 observational studies were found describing the effectivity of vaccination that included catch-up vaccination of all eligible adults in decreasing hepatocellular carcinoma prevalence and acute hepatitis B incidence. A prospective cohort study done in Korea among an exclusively male population showed a large reduction in the incidence of HCC among vaccinated persons that is comparable to persons with natural immunity when compared to chronic carriers. A cross-sectional study in Alaska in 1987 showed that after a mass vaccination program that included catch-up vaccination of susceptible adults, incidence of acute symptomatic hepatitis B significantly dropped. A study in Italy showed a significant decrease of incident acute hepatitis B cases after mass HBV vaccination. There were no randomized controlled trials that directly investigated the effects of catch-up vaccination among healthy individuals in reducing hepatitis B-related outcomes. In a meta-analysis by Matthew et al., adverse events were analyzed in 3 groups: systemic, local, and others. Common adverse events were pain, redness, and soreness at the injection site, and fever. There were no serious adverse events noted when the vaccine was given to pregnant women. The cost of vaccination in the Philippines is approximately 1,000 pesos. That's 250 to 300 Philippine peso per dose. Treatment for chronic hepatitis B is more expensive at 50 to 250 Philippine peso per day for an indefinite period. The cost of decompensated liver disease and possible liver transplantation may be insurmountable. Now, looking at hepatitis B vaccine in terms of equity, acceptability, and feasibility. An increasing number of vaccines have been introduced in the Philippines, but with most reaching at least 75% coverage. But hepatitis B birth dose coverage has never exceeded 40%. In the Philippines, 56% of births occur at home. In government health facilities, hepatitis B vaccine is provided at no cost. However, there are instances when there is a delay because of lack of vaccines. In private health facilities, hepatitis B vaccine usually are with cost. Because majority of the population in the Philippines are included in the lower socioeconomic status, vaccinations are not a priority. Educating the lay plays a vital role in making them realize the importance of hepatitis B vaccination. Therefore, partnership between the government and the private health sector is important in the implementation of policies and programs regarding increasing vaccination compliance. Here are the recommendations from other groups. The Advisory Committee on Immunization Practices recommends vaccination of adults at risk of hepatitis B infection and universal vaccination of adults in settings in which a high proportion have risk factors for HBV infection. They also recommend vaccination of adults requesting protection from HBV, even without acknowledgement of a specific risk factor. Follow-up testing is recommended for the following: healthcare workers, infants of HBs antigen-positive mothers, sexual partners of persons with chronic hepatitis B, chronic hemodialysis patients, and immunocompromised persons, including people living with HIV. Annual testing of hemodialysis patients is recommended given that immunity wanes rapidly in these individuals who are at high risk of continued exposure to HBV. Booster doses are not indicated in immunocompetent individuals if the primary vaccination series is completed, as long-term follow-up studies indicate that immune memory persists despite declining anti-HBs levels. But for individuals undergoing post-vaccination serological testing, especially immunocompromised patients such as persons on dialysis or with chronic inflammatory conditions including HIV, the American Association for the Study of Liver Diseases suggests a booster injection when the anti-HBs titer falls below 10 milli-IU per ml. Next clinical question: should vaccination be recommended to pregnant women who have no serological evidence of hepatitis B immunity to prevent maternal to fetal transmission and horizontal transmission? We recommend vaccination of pregnant women with no serological evidence of immunity to prevent horizontal transmission. However, there is insufficient evidence that this would decrease mother-to-child transmission. That's strong recommendation, but with very low certainty of evidence. Here are the considerations. Pregnancy is a period wherein both screening and intervention can be done to address newborn health. It is also the time when previously unvaccinated women seek consultation with the healthcare system and provide an opportunity to incorporate immunization to address the health of the mother to prevent maternal to fetal and horizontal transmission of vaccine-preventable diseases. Vertical transmission is the most common form of hepatitis B transmission in the Philippines. Hence, vaccination has been done as a measure to decrease hepatitis B infection in infants through the formation of protective antibodies that may pass through the placental barrier. 9 cohort studies investigated the efficacy, safety, and maternal transfer of antibodies to neonates after giving hepatitis B catch-up immunization during pregnancy. 388 out of 486, or 80% of the pregnant women given hepatitis B vaccine developed seroconversion. 158 out of 185, or 85% of infants had seroprotective levels of anti-HBs. No serious adverse events were reported after administration of the vaccine. As was mentioned, the cost of vaccination in the Philippines is approximately 1,000 pesos or 250 to 300 pesos per dose. Treatment for chronic hepatitis B is more expensive at 50 to 250 pesos per day for an indefinite period, and the cost of decompensated liver disease and possible liver transplantation may be insurmountable. Since the Philippines is a third world country, majority of its population belong to the low-income class group. Therefore, not all pregnant women can afford to receive hepatitis B vaccine. Government hospitals have free hepatitis B vaccines for indigent patients, but the supply cannot accommodate all pregnant women. Because of financial difficulties, some pregnant women are not able to screen for hepatitis as well as receive hepatitis B vaccine. Here are the recommendations from the American College of Obstetricians and Gynecologists and the Center for Disease Control. They recommend prenatal screening for hepatitis B for all pregnant women. All pregnant women who are HBs antigen negative and who are at risk for hepatitis B infection should be specifically targeted for immunization. The Philippine Obstetrical and Gynecological Society recommends that all HBs antigen negative pregnant women seeking STD treatment who have not been vaccinated should receive hepatitis B vaccination. The schedule for hepatitis B vaccination is as follows. For monovalent vaccines, the first 2 doses are separated by no less than 4 weeks, and the third dose is given 4 to 6 months after the second dose. So that's a schedule of 0, 1, and 6 months at a dose of 20 microgram per ml. For combination vaccines such as Twinrix, 3 doses are given intramuscularly at 0, 1, and 6 months, with each dose containing 720 ELISA units of hepatitis A and 20 microgram per ml of hepatitis B. These are our references. Thank you for your kind attention.